So, thank you very much for inviting me to talk. Last time at the RV Symposium a while ago, that was wonderful, by the way, and thank you, Jane, for inviting me. I talked about the proximal pulmonary arteries and how they affect the right ventricle. Today, I'm talking about activin inhibitors and specifically sotatercept, but specifically, we'll be talking about how the activin inhibitors influence heart function and the pulmonary vasculature. I'll be doing a little bit of engineering, thanks to Dr. Vanderpool, who's helped out with that, and so we'll go through that together. Let's see here. All right, so we're going to talk about how sotatercept improves afterload. We're going to talk about how it changes cardiac function, and then what's the time course, if you will, once we stop sotatercept before the disease comes back. And we'll illustrate that with a case. Okay, Dr. Rahagi, here you go. We just discussed this very topic and how important it is, nomenclature, right? So I was at a lecture at ERS, not this last one, a year ago, before that, when we were talking about disease modification. And somebody there put up a 6-minute walk test and said, you know, this delay of worsening clinical situation regarding 6-minute walk as disease modification. Now, I think if you ask 10 different pulmonologists in the room and 10 different cardiologists, you'd probably get a different idea of what disease modification is, much less reverse remodeling, right? But I'm going to just sort of put my neck out here and say what I think it is. Disease modification is slowing the disease, but not just through sort of surrogate markers, but addressing the causative factors regarding the disease. So, for example, in the world of heart failure, we all know that goal-directed therapy can not only modify disease, but also potentially reverse remodel the heart. What is reverse remodeling? Well, reverse remodeling means that the heart itself or the vasculature has reversed its course from a adaptive to a maladaptive to becoming adaptive and towards normal. So what that implies is that we know what normal is, right? I mean, we were just talking about this. With regard to the RV, that's difficult to say. There's not a lot of published data. There's some data from the MESA project, among others, but there are not a lot of great data on the RV outside of that. So when we look at reverse remodeling in the lungs, these are my criteria that I've laid out, and these are excluding the molecular changes which occur, which I think could be important as well. In terms of the pulmonary vascular disease, that means recruitment and increased distensibility of diseased arteries. So that, again, is an important factor, right? Because this is a heterogeneous disease. It affects certain parts but not others of the lungs. And when we look at RV remodeling and LV remodeling, keep in mind, even in patients with precapillary disease, there are some changes in the LV as well as the RV. So reduced mass of the LV, slight reduction in LVEF, which is not postcapillary disease. That has to do with underfilling of the LV. So increased LV mass, increased LV volume, reduced RV mass, and reduced RV volume, theoretically towards normal would mean reverse remodeling, hopefully. And that the heart is able to respond to stress. So what we're going to address today is I'll say activin inhibitors. There's one available by the FDA, which this case was sotatercept. And so we will discuss whether or not there may be reverse remodeling of the pulmonary vasculature occurring. And then sotatercept does the reverse remodeling of the heart, and the third factor we discussed already. So the case is essentially a 50-year-old patient. Her only past medical history was Graves' disease. She was diagnosed at our center in April of 2018, so a while back. Genetically, she did not have any known genetic mutations, at least at that time, and was initially started on parenteral treprostinil and one single oral agent, I believe was sildenafil. She was enrolled in SPECTRA, which is a open-label trial with sotatercept in September of 2020. Each patient there underwent cardiac MRI at baseline, 6 months, and 1 year. They also underwent invasive cardiopulmonary exercise testing. And I should have put the reference there, but this is Dr. Waxman and I participated in that trial, as well as Jane, in the Brigham as well as Arizona, and that has been published in Circulation Heart Failure last year, or maybe it was this year. In any case, she discontinued the sotatercept due to hypochromia, which is an interesting thing we have been seeing more of in our patients, actually, who have been on the medication. But she attributed it to that, and then her symptoms returned over a year later. So we for this analysis undertook methods including analysis of RV-PA coupling, which is a measurement of RV adaptation to disease, using single beat measurements and the MRI data for volumes. We also looked at the impedance spectrum, which is a gold standard essentially for afterload. And then we looked at distensibility and exercise pressure flow relationships during her exercise. So let's start with the vasculature. These are the typical hemodynamic, standard hemodynamics that occurred with the patient. You can see the patient's baseline catheterization, that's in the treatment-naive state, followed by dual therapy with treprostinil, parenteral treprostinil, and sildenafil. Then triple therapy was added, and that formed a basis for our baseline spectra, so it's initiation of sotatercept. And then at 6 months, 12 months, and then off sotatercept, those on the bottom. You can see on the left-hand side, we have two axes, the mean PA pressure and the cardiac output. You can see a dramatic drop in PA pressure, which continued after initiation of sotatercept down to somewhere in the upper 20s mean. Cardiac output rose substantially up to triple therapy, however, stabilized and may have actually slightly dropped by 6 months. And this is something that's been highly debated as to what is the cause of that. You know, typically when we see a drop in pressure, we see an increase in output, right? Some of the theories that have been brought up are one of the things that we have discussed previously was the drop in SVR with our typical drugs, causing a rebound or increase in cardiac output, whereas sotatercept causes typically an increase in systemic blood pressure. So that could be one mechanism, but the other mechanism, which is critically important to look at here, is whether or not sotatercept may be having direct myocardial changes, which may suppress cardiac output. That with PVR, then we saw a dramatic drop, and then it's sort of a stabilization on sotatercept. And with compliance, we saw a further increase. Of note, when the patient came off sotatercept, PVR rose slightly, and compliance dropped. So one of the things I think is important to bring up potentially is that when we see a drop in PVR with our typical drugs that we use to treat pulmonary hypertension outside of sotatercept, typically what we see is a very, very small drop in mean pressure, although there are occasions where specifically more on triple therapy patients might have a more dramatic drop in mean pressure, but more substantially an increase in cardiac output. And that's the mechanism of an increase in PVR. However, when patients are placed on sotatercept, it seems like the opposite occurs, right? So one potential, based on some research that has been done by the folks over at McGill, is looking at capillary recruitment as a potential model of reverse remodeling during exercise. And what we know is that, of course, this is a very small number of patients. If we look at patients who acutely vasodilate with inhaled nitric oxide, we know that that is a very specific phenotype of patients who, of course, other than living longer, will have a different distribution of perfusion and increased capillary perfusion. And this is indicated here with the FSCA, which is functional pulmonary surface capillary area. The point here is that once patients are placed on our traditional medications, there's very little recruitment as far as we know, whereas patients who see a drop in mean pressure, potentially there is some recruitment. Now this is a busy slide, but I'll go through this systematically with you. Distensibility is essentially a change in percentage change in the vessel area relative to a change in distending pressure. Did I get that right, Rebecca? Okay, thank you very much. So the thing that is important to know is that distensibility is really determined primarily by the distal arterioles, okay, so where the disease occurs. And it is one of the earliest things to drop and one of the latest things to improve, as far as we know, with therapy. In fact, most of our therapies have very little, if any, effect on distensibility. So if we look here, according to these exercise data, which distensibility is obtained during exercise, as we map out the curvilinear relationship of pressure and flow, which is normal. And to the point earlier, what is normal? Well, there is not a great reference range for distensibility, but what we can say is close to about 1.8 to 2% is probably normal. In this case, as the patient was placed on triple therapy, distensibility is 0%, which means that the vessels are stiff, basically like a lead pipe. As the patient's placed on sotatercept at 6 months and then 12 months, there's an improvement in distensibility, nowhere near normal, but one of the things that we have hardly ever seen previously with medication. And as the patient has come off sotatercept, there's then a decline in distensibility. Now, the impedance spectrum is a bit difficult for unseasoned folks who don't look at it all the time to comprehend. What it is basically a decomposition of pressure and flow by a Fourier transformation, which are generally essentially multiples of the heart rate if you go with a heart rate of 60-ish. But what the important things to mention about impedance are that it gives us a full display of both the pulsatile afterload as well as the static afterload, which would be PVR, essentially, as well as wave reflection and what's called characteristic impedance, which is the afterload determined by the proximal pulmonary vasculature. Essentially, the vessels just prior to the main point of wave reflection or pressure reflection in the system. One thing to note on the left-hand side is that this is a normal impedance spectrum. So as you can see, the Z naught is essentially equal to the total PVR, and the first impedance, the first harmonic impedance is essentially indicative of wave reflection as global compliance. You can see in the patient's impedance spectrum that there's a dramatic drop in the total PVR with a still much higher pulsatile load, which has declined even further as the patient's placed on sotatercept. And if we blow this up here to the sotatercept group, we can see that by 12 months, the patient's pulsatile loading has improved, whereas by 6 months, it really has not relative to the other time points. In other words, what we think may be occurring is that the distal circulation, as indicated by distensibility and by the impedance spectrum, may precede improvement in the proximal vasculature or potentially reverse remodeling of the pulmonary vasculature. And if we graph out the characteristic impedance versus alpha distensibility on the right-hand side, where the right lower portion of that would be the best, meaning the alpha distensibility is high and the characteristic impedance is low. You can see the initial drop in impedance is not met with in change in distensibility until the patient is placed on sotatercept. Another thing that I looked at in this patient is examining the changes in dead space, which this is sort of one of my little thought experiments that I put on paper. If you can see, there's 2 time points for every, or 2 points for every catheterization. So the upper time point is rest and the lower is exercise. And if you look here, patients who have pulmonary vascular disease are known to have increased chemosensitivity to the brain. That could be due to several factors, such as reduced cardiac output causing an enhanced ergoreflex, or changes with the skeletal muscles themselves with feedback to the brain. There's various theories, but nevertheless, increased chemosensitivity is a poor prognostic marker, as well as dead space. So again, being in the bottom right portion of that graph is the best place to be in. And as you can see, there is not only is there improved chemosensitivity as the patient as the time point or the graph points move to the right and lower, but there's also reduced dead space on sotatercept. So let's move on to the heart. Here are the patient's MRIs. Starting at baseline and then going to sotatercept at 12 months. We don't have an MR after she stopped sotatercept. You can see on the far right, the patient's RVEF at baseline prior to treatment was 36%. This was accompanied by actually a slight drop in EF on dual therapy, and then an improvement again on triple therapy. The EF remains stable in the 50% range, which is normal. Normal, I'll put that in quotes. But the volumes had dropped dramatically, and I just have for clarity on here the RV volumes on sotatercept. This is very similar to what we saw in all the spectra population, by the way. If you look at the coupling metrics of the heart, we can see on the left that there is contractility, which is the right ventricular elastance, and the afterload, which is global measurement of afterload, which is the vascular elastance. We can see the vascular elastance has dropped and then remains stable on sotatercept. However, the contractility remains high and then drops at 6 months relative to that point we already discussed, and then rises again by 12 months and then drops again once the patient goes off sotatercept. There's a few salient points here. One is that what relative to normal, what is normal right ventricular elastance is much lower than we see here. And in fact, with the patient on double and triple therapy, as far as we know, what would be a threshold or a peak right ventricular elastance that a patient can generate during exercise is probably somewhere close to there, or just slightly higher. What we've seen is about 3.5 to 4. So in other words, although the patient may have a coupling ratio which is normal or high, the patient's RV is working really hard to do that. So it is compensated, but barely, and during exercise may not be, right? And the other salient point here is that although the coupling ratio on triple therapy and at Spectra at 12 months are fairly similar, notice that the EES, or the ventricular contractility, is much lower, indicating that although the coupling ratio is approximately the same, the RV is in a much better spot energetically. And I'll show you some data to support that. So in other words, one thing that I think that is important, and I would stress this to many people, is we all say the coupling ratio is the gold standard. The coupling ratio just tells you whether or not in that state at rest the patient is the RV is compensated or not. But it doesn't give you the full explanation of what might happen when the RV is stressed. And this idea is well elaborated by Dr. Westerhoff and his group in Amsterdam, who said, because uncoupling will only occur in end-stage disease, the adaptational mechanisms to maintain coupling are more interesting to measure than coupling itself. And our group has published some data on coupling showing that it is relatively stable or changes minimally over time, whereas other measurements of RV compensation may be equally or perhaps more important depending upon the context. Coming back to the important or salient discussion then is that although the contractility has dropped by 6 months, the stroke volume of the right heart, which you can see here, is maintained or increased. So how could that be if contractility has dropped? Well, what's also happened is that the diastolic stiffness of the heart, you can see by this line, has improved dramatically. We're not sure exactly why or how that could be on sotatercept, whether it's affecting fibrosis of the myocardium or other elements, or it may just be a manifestation of reduced afterload. But in any case, what that indicates is that the Starling mechanism is now kicked in and is sensitive to changes in preload. As the patient went off sotatercept, you can see stroke volume has dropped. And then if we go to changes in stroke volume with exercise, what I'd say is the sort of the third criterion for reverse remodeling, you can see that even though, as I pointed out earlier, stroke volume actually dropped with exercise in the patient on triple therapy, even though at rest the coupling ratio was normal. As we move towards the Spectra data at 6 months and 12 months, see here, even at 6 months, there is a dramatic improvement with exercise and stroke volume, indicating that there is RV reserve. So potentially what I would interpret this data as at 6 months, although contractility has dropped, and we need to do more investigation as to why that might be. The changes in diastolic stiffness that are occurring more than overcome those dramatic changes or those drops in contractility. Whether or not that might be an important factor for someone who's teetering on the edge when they're started on sotatercept, I don't know. So sotatercept treatment seems to improve both steady and pulsatile elements, I think, but it doesn't completely normalize it. So if it is reverse remodeling the vasculature, it's not completely reverse remodeling the vasculature. The distal reverse remodeling, if it is occurring, may occur before the proximal, but both are occurring at some point. And that the sotatercept results in probable reverse remodeling of the heart. This has to be backed up by more data. Early cardiac effects of sotatercept deserve special attention, like I said, especially in decompensated patients. And in the beneficial effects of sotatercept may still be present at 2 years after stopping, although there is some return of disease. And I wanted to thank Dr. Vanderpool again for helping me with the bioengineering. Thank you again for that. And thank you again for the invitation to present.
Yeah. Thanks so much for that great presentation. I mean, that's just an incredible survey of hemodynamics with sotatercept. So, any questions? Go right ahead, Hap.
Yeah.
So one of the other thoughts about
Hold on for a microphone.
one of the other thoughts that's been bandied about how sotatercept actually improves all of this without actually changing your cardiac output is by changes in your hemoglobin and stuff like that. What do you think about that?
Yeah, so if you look at the Spectra data, there are lots of things going on, and I've chewed through this over and over and over. But you're right, when we see improvements in oxygen consumption with exercise, it's mainly attributable to increases in hemoglobin. That's not to say that the changes that we see with the heart aren't advantageous. Like I said, the heart's not working as hard, right? And who knows what would happen if there was something different if sotatercept didn't improve hemoglobin. Yeah, so, I mean, we don't know that. Supposedly there's some new activin inhibitors that don't change the hemoglobin. I don't know. Do you know about it? Are there some that don't? I don't know, but supposedly is the answer. So, yeah. Did I answer that for you at all? But yeah.
It's a very difficult thing, but that is probably part of it.
Yeah. Yeah.
Yes, so let me ask you too. You mentioned that there was a reduction in dead space, right? And so usually when someone talks about that, I start thinking that either there's an increase in recruitment of, vasculature that's already there, or there's an increase in collateral flow, or there's an increase in neovascularization. So do we know what the mechanism of this is?
No, I mean, I would assume and hope that it's reverse remodeling, recruiting capillaries that are, but we don't know.
You don't.
Yeah,
I mean,
you don't know.
I would say you don't know that, especially when you have neovascularization.
True. Yeah.
With the drug.
Yeah. So if we posit neovascularization, or are you getting at, are there AVMs?
Well,
forming?
I'm just curious. I mean,
Yeah.
it could be.
Then you would see hypoxia, right?
Or
Maybe.
you could get, like angiogenesis or something like that. I think Paul.
Yeah.
be able to speak to this better.
Thanks for that beautiful talk. I really like the changes in compliance that seem to be durable after that. And I know this is in your really nice paper, and there's also another series of patients that were described too, where people had tracked DLCO as a marker of improvement. And it would cover a few bases, but it would cover potentially the diffusion barrier being improved by reverse remodeling, potentially. But it would also be, I wonder what the effect of intrapulmonary shunting would be. In your patient, did you see changes that were durable in DLCO and in others?
We didn't, on our idiopathic patients, we don't usually repeat that, PFTs that often. I mean, that's a good point. Maybe we should. Are you referring to the paper by Marius Hooper? I think it was based on
That's right.
some patients from the Stellar data.
Exactly.
Yeah. Didn't they find that it didn't improve the DLC? I can't remember, to be honest, but yeah.
Improved a little.
It improved a little?
Yeah.
Okay. Yeah.
Yeah, it was a small sample.
Yeah, it was like less than 20 patients or something like that. Yeah. No, but it's important. It's important data. Yeah. I'll keep that in mind. Maybe I'll do she's back. Our patient's back on sotatercept, by the way.
Oh,
So we'll see. I don't know. Maybe we'll have take 2 in a year when I.
what happened to the
Present
skin findings after you stopped and after you restarted?
So she had a bunch of stuff going on with dermatology, but they did eventually improve a little bit. But she's very, she was very upset about it initially. She has naturally dark skin tone, and it's very, very obvious, when you look at her. It looks like vitiligo, and they treated it as vitiligo. The dermatologist did, but since she started back on sotatercept, it does look to be worsening again. So I don't know the mechanism. Maybe you would be the first to tell me.
Did she get on any immunosuppressive therapy for the vitiligo?
Yep.
Okay.
But it seemed like they were kind of just pulling stuff out, and there was some sort of phototherapy she had also, and I don't know, that's way outside my wheelhouse. But yeah.
Interesting. Thank you.
Yeah.
All right. Any additional questions? All right. Well, thank you so much
Thank
for
you.
this terrific talk.